Dredef, Healthcare Stories. Carol Gill and Larry Voss are being interviewed in the living room of their home in Darien, Illinois. Their interviews are presented in 6 parts. This interview is part 6.
I think medical and nursing education is getting, more high-tech and more intensive about developing these competencies around how to use machines, how to use monitors, and also the legal aspects of how do you document what you've done and doing the paperwork. But while it's expecting people to have these incredible competencies around technology and maybe around particular interventions, intervention protocols, on the other hand, I think there's a real dumbing down of health professional education in terms of troubleshooting, building interactive relationships with patients.
Really getting to know patients.
Getting to know patients.
And not just the readouts on a machine.
Yeah. Getting to really troubleshoot and have intuition about, and by intuition I don't mean anything mystical. I mean the insight that comes with experience and thinking. I think there's less thinking and reflection about the patient and what's really going on, and seeing that patient as a whole individual. And those 2 words are really important. The whole person and the person as an individual. The whole idea of personally assisting someone seems to be considered an intrusion and something inappropriate or problematic, rather than something that would be an intrinsic part of healthcare. I still remember the days when nurses would hold your hand, give you back rubs, things like that, and they gave you back rubs to make you feel better, and I think to hands-on get to know you and acknowledge you as a person that they wanted to comfort. There is not only no time for that, I think we have a whole generation of health professionals who are not motivated to do that. That's not why they came into the profession. I think it helped health professionals build a relationship that led to more complete, informed, and better health care. Now, I don't need a back rub, but what I do need is someone willing to help me turn, who's not afraid to touch me, to just hands-on be another human being, helping another human being, working it out, and letting me do this the way I want to do it, rather than say, as I've been told repeatedly, why aren't you catheterized? It's too much trouble helping you. They will actually tell me that.
I think, the lack of getting to know patients as individuals and communicating and having contact with patients as people and not just numbers that are being shown on a monitor is significant for all patients in the hospital setting. But I think for people with disabilities, it's much more, crucial and has much more significant, threats to the person's survival, because we have sometimes very unique ways of living and of moving and of, going through our day's activities. And if we don't have support doing those, sometimes it can be very threatening to us.
I've written about that and called it constructive vulnerability. And I even wrote an article, and one of the examples I gave is a friend of mine is an occupational therapist, and she has a disability. And she married a man with a disability as well. And when he was hospitalized, he was not helped up out of bed. And that's another thing. The acute hospitals are extremely bad at helping us out of bed when people with physical disabilities are hospitalized. They don't have enough lifts, like Hoyer lifts. If they do have them, personnel are not adequately trained on how to use them. Most of them don't even know where the lifts are kept. The lifts are not kept charged if they're electrical. In other words, the message comes through loud and clear that, yeah, we have this stuff, but we just aren't, we're not a system that is geared towards helping you out of bed. If you're sick, stay in a bed. And that's really bad physically for a lot of us with disabilities. It leads to pneumonia and pain problems and decreased stamina, and it prolongs our recovery and sometimes completely, retards our recovery. My friend's husband was kept in bed, and yet he was told if he's going to get better, he's got to eat. But he was also told that, they noticed in his records that even though he was disabled, he could feed himself. So here's your tray, feed yourself. And he couldn't in bed because the way his arms worked, he could feed himself quite well if he were sitting at a table and could prop his elbow up on the table. But in bed, he had nothing to prop his elbow up. So he would say, I can't do it in bed. I need assistance. And so then they said, either he is purposely asking for more help than he needs, or he is losing functioning. In either case, he is becoming more dependent. And we can't, not prescribe, but we can't support the idea of his then being discharged to home. He's going to have to go to a nursing home. And he certainly can't go to rehab because he's getting more dependent. He's not going to pass those tests for rehab. So they started a discharge plan to discharge him to a nursing home. And his wife, who is both physically disabled and an occupational therapist, got wind of it, and she went into action and said, look, you caused this problem by not getting him out of bed, not allowing him to eat in the way that works for him, and he is not going to a nursing home. And she, went into action and got him what he needed. Now, what if he didn't have a wife, or a wife who was disabled and an occupational therapist? How many people like him are getting shuttled into nursing homes? And we all know what happens to so many disabled people in nursing homes. They end up dying because one thing leads to another, and it spirals into a decline. So these narrow escapes that someone like that man had are really terrifying. They should be anyway. But because they're happening to people with disabilities who are already viewed by a lot of health professionals as complicated, fragile, vulnerable, well, of course they're going to get worse. Of course they're going to die. I think that there is less alarm about us. There's less concern. Our lives have value even though you can't see it as a health professional because your goal is different from what we are, which are people who function between perfect bodies, perfect health, and death. Doctors are good at either end. They're not good in the middle of someone who functions differently, has health problems, but still lives a full and really good life. They just don't get that in between. What we need is, in addition to addressing all those problems, is we need to look at disability as a facet of cultural competence. And failing that, because I know that would move slowly and have probably delayed effects, and I want things to get better like tomorrow, because I don't have forever to live, and I want it to get better in my lifetime, is I think we need a system of advocates so that people who don't have a spouse or even a personal assistant who can be with them 24/7 in the hospital will have someone. I think it's time for healthcare professionals to realize that hospitals are dangerous places for many people with disabilities, and we need protectors. We need protectors who know us, know about our lives, are culturally competent about disability and won't leave our side.
Healthcare Stories, made possible with generous support from the Manuel D. and Rhoda Mayerson Foundation. Carol Gill and Larry Voss were interviewed at their home in Darien, Illinois, July 2011. For more information, visit the Disability Rights Education and Defense Fund website, dredf.org/healthcare-stories. This work is licensed under a Creative Commons Attribution Non-Commercial Share Alike 3.0 Unported license.